So without further ado, I wanted to introduce our first speaker, who is Dr. Larry Greenbaum, who serves as Division Director of Pediatric Nephrology at Emory School of Medicine and also Children's Healthcare of Atlanta. He's the co-author of many textbooks, many of which you probably have read. And I think the most important thing, having worked with him over these past couple of, year or so, he's an eminently kind and patient pediatrician who is very passionate about what he does and passionate about helping kids throughout the state of Georgia. So without further ado, I'd like to introduce Dr. Larry Greenbaum to speak with us about telehealth and what's going on.
So I'm really delighted to be here with you today. Really participating in this program is one of my great joys of my work these days. I do lots of different things, but participating in this program and partnering with the program here at Mercer is really the thing I enjoy the most of all the things that I do. And I'm going to be talking to you today about telehealth. And this is sort of an overview of what I'll be doing. I'm going to give you a basic overview of telehealth, some background, barriers, opportunities. I'm going to present a number of studies where people have looked at telehealth and its impact, just to give you an idea of its potential. I'll talk to you about our telehealth program at Children's and what we're doing, just to give you some background. And most importantly, I'll be talking to you about our partnership and the program that quite a number of you are involved in, which is a program to bring telehealth subspecialists into pediatric offices, which I think has a tremendous potential to improve the care of children in rural Georgia, and that's why I'm excited about it. So this is kind of a history of telehealth. Some people say, telehealth has been around for 1,000 years, back when they were using bonfires to warn people about the bubonic plague. It was a way of communicating without being right next to someone. During the Civil War, telegraph was used to relay needs for medical supplies and so forth. The telephone, of course, was introduced in the 20th century, and people were able to start communicating that way. Radios during the World Wars to bring in healthcare resources, also to give advice to people in the field about what to do. And NASA, of course, in the 60s and 70s, started doing telemonitoring of astronauts and recording physiologic information, something that I think, as you'll hear, is something that we are able to do now in patients all over if we like. The first interactive video link was out in Nebraska, where in psychiatry they got advice from a central hub 112 miles away from the hospital. And then in Boston, the Massachusetts General Hospital was communicating with Logan Airport. So when someone came off the plane in extremis, they were able to get advice through video and other resources. Obviously, the internet has really transformed our capabilities in telehealth. And, we started doing telehealth, using the internet, soon after it became available. COVID-19 obviously had made a huge impact on telehealth. There was a surge of telehealth because people just didn't want to come and be seen in person. And frankly, the medical providers didn't particularly want the patients to come in and be seen in person. Everybody was scared. Pretty quickly, we returned back to normal, sort of. And most visits are now conducted in person, just like they've always been. But that COVID surge really created a new mechanism for telehealth, which is in-home visits, which wasn't available before COVID, and that has been maintained. How much has varied from from institution to institution, but has really provided at our institution and many institutions a tremendous increase compared to almost rare telehealth visits to now at least it's a percentage of our a small percentage, but it's a important percentage of our healthcare visits. So some basic definitions and lots of ways of defining this, but telemedicine says the use of electronic information and communication technologies to provide and support healthcare when distances separate the participants. So this is sort of direct patient health services. Patient is at home or patient is in a school-based clinic and the physician is at a different location and we're having direct interaction. Telehealth includes telemedicine, but it also includes health information sharing. So, for example, our radiologists are able to access imaging all over the state because that imaging is available and it can be brought in. Health profession and patient education can be done via electronic communication, usually video communication, and is really a tremendous opportunity as well. And then finally, remote or patient monitoring. We're starting to use Bluetooth blood pressure cuffs to upload blood pressure data and be able to get that uploaded directly to us as opposed to someone looking at a screen and writing it down and maybe making a mistake and then waiting for that to be written down and sent to us as a scanned image. We're now able to just have that loaded up, and obviously tremendous potential in a variety of different diseases. Applications of telehealth, they can be live video conferencing, synchronous telehealth, which is what we all think about, but it also can be asynchronous, again, storage of images, storage of data, and then have that communicated, even, storage of a physical exam that somebody else does and somebody else watches it later on. And then finally, remote or patient monitoring, as I mentioned before. All right. So obviously a lot of the advances in telehealth has been fueled by changes in technology. Before I moved to Georgia 18 years ago, I didn't own a cell phone. When I was on call, we had a division cell phone. I think it looked something like this. It was big and clunky, and we would pass it between who was on call. And that was just so that when I walked my dog and I got a page, I could answer the page. Didn't actually use the cell phone to call anybody. I didn't even know how to dial the thing. But, or nobody called me. It was really just used to make an outside call if I happened to be away from a landline. And at the time, I was thinking, why would I pay $50 a month for a cell phone when I have a perfectly good landline? Seems pretty old-fashioned now, but that was kind of the thought process. I kind of realized I needed to get a cell phone when I moved to Atlanta, and so got my first cell phone. Some of you are probably a little ahead of me, but that was really the time. It was really, 18, 20 years ago that people started using cell phones. And of course, they weren't smartphones, but the technology has really driven a lot of what we can do in telehealth. Our availability for connection to telehealth in homes has increased, although as you'll see, not as widely as we'd like. What we can do in terms of uploading things, doing oscillatory exams during a telehealth visit, all driven by constant improvements in technology, and obviously that will probably continue. I would like you to take out your cell phone now. I usually, when I give a talk, I tell people, put away your cell phone, because I don't want you doing, texting while I'm giving a talk, because I want you paying attention to me. But I want you to take out your cell phone, because we're going to do a few questions and surveys during this talk. And this is something called Slido. So if you scan the little QRS code, you can put in an answer to why do telehealth? What do you think are the the things that make you think that telehealth is a good thing to do. It says you can only put one word in, but you can put a phrase in if you like. I tested that this morning, and you can put a phrase in. So once you get up and running, and I think there'll be 2 more questions, but once you do this once, the next questions will come in to your phone, so you won't have to do the scanning each time. But I'll give you a little bit of time to write in your answers to why do telehealth. And all right. So this is a word cloud. Convenience, access for the patient, convenience to patient, availability, accessibility, for comfort, flexibility, access. Although convenience is quite popular. For the patient, specialty care. All right. Lots of good input. Yeah, I mean, I think these are all great answers and they're all true. There's not a right answer, obviously. But I think giving patients better access to care, more convenient care, are critical components of this. But you'll see during, hopefully, the rest of this talk that there are a variety of other reasons for doing it. Thanks so much for participating. You guys are great. For potential of telehealth in pediatrics, very simple, improve access for children who live in distant communities. I have patients who, if they drove to see me, it'd be 3.5 hours each way, 4 hours each way. I can't imagine driving 4 hours to spend 20 minutes with me and then having to drive 4 hours back home. And, if we can minimize that as much as possible, I think we're doing something really positive. Decrease disparities to access to care. If you've got resources, it's not so bad driving up to Atlanta. I mean, we've had patients from rural Georgia who fly up to Atlanta for their appointments. That's a whole different story for most of our patients, obviously. We can utilize the pediatric workforce more efficiently. I do outreach clinics, but if half of those clinics could be done via telehealth, that saves me 2 hours of driving, and that's 2 more hours I can spend seeing patients. Decrease no-shows and canceled appointments. That's good for our practice. If someone has to drive 3 hours, they may cancel that appointment, or they may not show up because they don't have gas, or Medicaid transportation failed them, or a whole host of barriers to coming up to an in-person visit, especially if you live far away. And change the way care is delivered. Enhance communication between providers. That's one of our goals of this program that we're doing, partnering with pediatricians here in rural Georgia. More efficient and less costly care. You can, if you're seeing the patients, they're hopefully not ending up in emergency rooms. Higher quality care, I have no doubt about that. If we're able to connect with our patients because they're able to use telehealth, I think we're going to give higher quality care. And the great thing is it works as we hopefully at some point transition for a fee-for-service model to alternative payment models, because we can provide even better care via telehealth if our only purpose is to care for the patient as opposed to worrying about getting paid for the services that we provide, and just focus on the quality of care that the patient receives. Access to care. There are a lot of geographic barriers. More than 17 million children in the United States live more than 1 hour away from a regional children's hospital. That's a lot of kids that don't have reasonable access to care. And there are barriers. There's a maldistribution of pediatrics and subspecialists. In my field, pediatric nephrology, there are entire states that have no pediatric nephrologists. And these are not small. This is not Rhode Island. These are huge states that have no pediatric nephrologists. And so how can we get those kids better care? Again, probably through telehealth. Barriers for rural patients, urban patients. Frankly, before this program, I was very focused on getting our urban patients that were socially disadvantaged access to care, working with school-based clinics, things like that. So there's lots of urban patients that have the same sort of barriers that rural patients have. It's not so much length of distance, but it's just being able to get into the care that they need. Rural pediatricians report greater barriers to accessing subspecialty care than non-rural pediatricians, not a big surprise. And lack of access to care leads to increased ED utilization. Lots and lots of data about that. You can't see someone, you're going to end up in the ED, not a very cost-effective or effective care that you're going to receive for a chronic problem in the emergency room. Health disparities in rural populations, less access to general and pediatric and specialty pediatric care. We know that there's a shortage of pediatricians. We have strategies for trying to address that, as you know, but we also obviously have poor access to subspecialists, greater travel time, less commercial insurance, which is another barrier to care, higher rates of chronic conditions in adults, many of which start in pediatrics, in children. And so there's a tremendous opportunity of impacting adult health by getting these kids access to care. And you're going to hear from Dr. Walsh later today about the importance of addressing overweight and obesity. Increased risk of low health literacy. We know that low health literacy is associated with decreased educational levels. We also know that low health literacy leads to poor health status, leads to barriers to proper care. And so these patients in rural Georgia have a lot of barriers to care. And if you put 8 hours of driving to do a 20-minute clinic visit on top of that, you're really going to magnify the problem. This is some data. This is what's called the Hospital Capability Index. And it's basically a measure of when a kid shows up in an emergency room, do they stay in that hospital or do they go somewhere else to get care, some sort of tertiary care location that, frankly, most of the time is way far away from that patient's home if they live in rural Georgia. And what this shows is that in both children and adults, that has been increasing. More and more kids are needing to leave their communities to get care. And it's about 11% decrease over these 10 years. This is a little old data, but this trend is definitely continuing in adults. But the decrease is 36% decrease in kids that are staying in their communities for care versus what it was 10 years previously. So unfortunately, we're going against the trend, which is we're trying to keep kids in their communities, and the trend is they're leaving their communities. What state do you think this is? You probably think, is this, Nebraska, Mississippi? It's actually Massachusetts. So, and it's true in many states, Florida, Massachusetts, New York, California. More and more kids not staying locally, but being transferred to a tertiary care center. Now, that might make sense if the kid needs a, heart transplant or a liver transplant, or they need brain surgery. We're obviously not going to have that in every hospital for children, every hospital that takes care of kids. But it's not that. As you see in this slide, kids are leaving for things as simple as abdominal pain, asthma, urinary tract infections, non-infectious gastroenteritis. They're being transferred out. That's increasing as well. This is pediatric data. We would like to reverse that, and I think telehealth can have a role in enabling more local facilities to hold on to those kids and avoid transferring them. Rural-urban differences. This is a study of rural children with special health care needs. What is known is there's more poverty in these kids. There's lower maternal education level. They're less likely to be cared for by a pediatrician. They're more likely to be seen in a clinic or a health center, so they don't have a medical home. That's going to interfere with their ability to get the care that they need. They're more likely to have delayed health care due to the type of due to the fact that the type of care needed was not provided in the area, or not having the money to pay the provider, and more likely to report unmet need for care due to not available in area or transportation problems. So this is what the families of these kids with special health care needs are saying, that they're just not getting the care they need if they live in a rural part of the United States. Benefits of telehealth: decreased parents missing work and loss of income, decreased children missing school. Yeah, they may need to miss an hour of school, but they don't have to miss an entire day of school. Decreased costs, risks of travel, high quality care. So they're getting access to the type of subspecialist that they need in a timely fashion. High satisfaction has been shown, both patients, providers, and caregivers. Reduce risk of infection, obviously during COVID. Equivalence to in-person encounters. This is not, we'll make do with a telehealth visit. This care is just as good as in-person care if properly done. And then increase local providers' comfort level with managing a condition from multiple observations and interactions with a subspecialist. So if there's a collaborative relationship between subspecialists and pediatricians, rural pediatricians will become more comfortable with managing many of the conditions that would otherwise be referred by a subspecialist, or could be jointly managed by a pediatrician and a subspecialist, as opposed to all the care provided by the subspecialist. This is some data, a variety of studies that have been published. Primary care sites, and again, this is primary care telehealth. If a site has telehealth implemented, there's about a 23% increase in clinic visits and a similar decrease in ED visits. Where do you get better care? More cost-effective care in the office, not in the emergency department. And those kids in the emergency department have probably gotten sick, and that's why they're there, as opposed to being managed in the office and getting higher quality care. Teledermatology. This is fascinating. This is a study of 1,500 patients. These are adults. Teledermatology led to a change in diagnosis in 70%, change in management in almost 98%, and an improved clinical outcome was associated with change in diagnosis, change in management, and number of teledermatology visits. So I know that there's not probably great access to pediatric dermatology here. And I think that's a tremendous opportunity. Pediatric telepsychiatry. This is a study out of Wyoming, certainly a very rural state. They did telehealth, televideo consults, remote medication reviews, telephone-based consults. What were the outcomes? There was a 42% decrease in psychotropic medications in children less than 5. There was a 52% decrease in children using psychotropic doses that were more than 150% of the FDA max. And televideo redirected 60% of children from residential treatment, inpatient admission, to using alternative community treatment and placements that avoided those hospitalizations. This program, telepsychiatry, saved $1.6 million, even including the $0.9 million cost of the program. So you invest in the program, but in the end, you save a great deal of money. Home monitoring for asthma. This was a randomized study. Either they stayed office-based with 6 clinic visits over a year, or it was a virtual group. They had 3 clinic visits and ongoing virtual support. Improvement in their asthma diary compliance in the virtual group, greater improvement in knowledge and inhaler technique in the virtual group. There was no difference in clinical outcomes. So unfortunately, they didn't show a significant improvement there. But obviously, it's suggestive that these types of programs can result in improvement if the kids are using their inhalers better, if they're keeping track of things better. Hopefully, eventually, you'd be able to show improvement in clinical outcomes. But just being honest, they weren't able to do that. Emergency department consultations. This is another initiative that we're working with. Telemedicine versus phone. Benefits, if you compare the two, 31% decrease in transfers, keeping the kids in their communities. Cost savings, almost $5,000 per patient. Really fantastic data, adding that telemedicine, and that's something that we're working on. Project Echo. How many of you have heard of Project Echo? Yeah, so this is a program that was first done in New Mexico to address treating patients with hepatitis C. It was found that a lot of rural primary care providers, these are mostly adult providers, really didn't feel very comfortable treating hepatitis C, but it would be very difficult for their patients to be constantly traveling to Albuquerque. So they set up this Project Echo, which is really educating local primary care providers about how to treat hepatitis C. And there's a telemedicine link, patient case presentations, mentoring, a variety of different strategies. And the end result was, you can see the reference here, was published in the New England Journal of Medicine because of how dramatically effective it was at improving the ability of primary care providers to treat hepatitis C. And this ECHO approach has been now used in a variety of different areas, and I'll show you some data from one area. But I think this ECHO approach is something that we can use in some of our initiatives here in really helping primary care providers feel more comfortable with addressing common pediatric subspecialty problems, so that there can be either partnership or just independent treatment of those issues. Echo Autism was done in Missouri with pediatricians, and the result was pediatricians who participated felt much more confident in their ability to assess and diagnose autism, and they were much more compliant with AAP screening guidelines. They went from about 30% to 60% compliance with those guidelines, not 100%, but obviously a doubling of results. And I think this is another example of ways that we can really push the envelope and improve care. And this is using telehealth technology to provide that education, mentoring, and feedback to enable primary care providers to provide their care in their community. This is a virtual collaborative obesity education, rural primary care clinics, caring for children, intervention, virtual QI learning network to implement best practices and exchange strategies for improvement. And what they found was increase in weight assessment and counseling. Children had improvements in nutrition and physical activity. So concrete benefits of this type of ECHO program. And just in child neurology, a COVID-19 implementation, just to talk about just provider satisfaction, 93% considered the visit satisfactory, even though it was telemedicine. Neurologists usually love their physical exam, but they still were able, most of the time, to have a productive visit. And almost 90% of the time, they suggested telemedicine for follow-up. Only 5% needed a subsequent in-person assessment. And parents and patients and caregivers were equally enthusiastic about future telemedicine visits. So providers like it, patients like it. So maybe we should do it. Asthma management via school-based clinic. This is a rural school-based health clinic. The program, 6 months, 1 in-person visit, and then telemedicine at 4, 12, and 24 weeks. Outcomes, 83% increase in symptom-free days. These kids were doing so much better with their asthma by introducing this telemedicine component. And then the quality of life improved both for the patients and for the parents because they weren't dealing with sick kids all the time. They weren't going to emergency rooms. They weren't worrying about their children. Diabetes management via school-based telemedicine program, type 1 diabetes. And again, randomized study, usual care, medical visits every 3 months, and then the usual communication versus usual care plus monthly video conference with a school nurse, the child, and the diabetes team. Outcome? Hemoglobin A1C was higher in the usual care group. Hemoglobin A1C was lower, came down in the intervention group. Tangible benefits to patients. The intervention group also had decreased urgent calls by the school nurse to the diabetes team, decreased hospitalizations, and decreased ED visits. An example of another really effective way of using telehealth, bringing it into school-based clinics. And in South Georgia, just to bring it home, telemedicine for sickle cell. It was pediatric patients followed at Augusta University. It was mostly hydroxyurea follow-up and newborn screening, confirmation, and education. And the bottom line is everybody liked it. It was well received, and you can see the tremendous potential there as well. And again, do they want to use it again? Yes. All right. Get out your cell phones. This is a quiz question. In this case, this is the only one where there's a right answer. What is the digital divide? Is that iPhone versus Android users? Is it the gap between people who have access to modern information and communications technology and those who don't? Is it the part of the Grand Canyon where there is poor cell phone reception? Or is it the gap between providers who offer telemedicine to patients and those who don't? So what is the digital divide? I'll give you a few minutes to answer, or a minute or two. Okay. I'll make sure I'm doing okay on time. All right, let's see how you did. Okay. All right, no one went for the Grand Canyon or iPhone, Android. So it's actually the gap between people who have access to modern information and communications technology and those who don't. It's more focused on the patient than on what the provider wants to do. All right, and this is my backup slide in case the Slido didn't work. So barriers to healthcare and telehealth and telehealth. Healthcare barriers, geography, distance, education and health literacy definitely interferes with providing care. Families that don't have poor health literacy, we see it all the time. Mistakes are made, communication errors occur, wrong doses of medicine are given. Socioeconomic barriers obviously interferes with getting to clinic visits, affording medications, affording access to technology, access to health insurance, structural racism and discrimination, and language barriers. Certainly people who don't speak English often struggle with getting the care they need due to communication problems. The digital divide, rural populations are less likely to use telemedicine. Does that make sense? Someone in metro Atlanta is more likely to use telemedicine than someone in rural Georgia. Why is that? Well, broadband. Unfortunately, payment for telehealth requires a video connection. You can't do it over the phone. And if the family does not have decent internet access, they may not be able to do video communication. Equipment. Fortunately, nowadays, almost everybody has a smartphone and you can do telehealth on a smartphone. But obviously, it's a lot nicer to do it on a computer with a big screen. Everybody's sitting in front of a chair and communicating. So that can be, and if you can't afford a computer, you don't have that option. And maybe your cell phone, you didn't pay your bill and it's no longer working today when your telehealth visit's supposed to be. digital literacy and language barriers. Patients may have the equipment, but when they go to log in, they struggle because they don't have that much experience with doing things digitally. So when those steps that we try and make as easy as possible for logging into their telehealth visit, they may struggle with. The audio may not work, the video may not work. Come to think of it, the last time I did a Zoom call, my audio and video didn't work either. But it happens to all of us, but it's obviously more likely to happen in people who don't have that much experience, aren't used to doing Zoom calls and WebEx like many of us are. Lack of private space. You want to have a private conversation with a teenager, but there may not be a room in the house where you can do that. You may be trying to do the telehealth visit, and I've had this experience, and there's just lots going on in the home, and it's hard to hear, and it's difficult because there's not a nice, private, quiet place in the home to do it. And primary care offices in rural Georgia tend to be under-resourced, so it's going to be more difficult for them to do telehealth in general. I'd now like to shift gears and tell you about telemedicine at Children's Healthcare of Atlanta, our journey, the good and the bad. It really started we started doing telehealth, I think it was about 13 years ago, 14 years ago. And the first place to do it was actually our Child Protection Center. And I can say that with certainty because my wife ran the Child Protection Center. And she did both educational work through the Georgia Partnership for Telehealth, which is now called the Global Partnership for Telehealth. And she actually did even physical exams through telehealth at very sophisticated presenting sites. Subsequently, a group of us started doing subspecialty care. We got the program running, and we started doing subspecialty care through the Global Partnership for Telehealth. This is what I sometimes call old-fashioned telehealth. There was a presenting site. The patient would go there. There was equipment. There was a stethoscope, otoscope, etc. And then we would video conference in with them. And it was very effective, but there were limited sites for pediatrics, and it had a pretty low uptake. Over the subsequent years, and I really wasn't very involved in telehealth until after COVID, in subsequent years, they started thinking about some alternative models. They were thinking of setting up some children-specific sites to enable visits to occur more efficiently. That never happened. And then we had COVID, and that sort of jump-started telehealth at Children's. Obviously, we went from, less than 1% of subspecialists doing telehealth visits to 90% of our visits were telehealth. But quickly, within about 3 or 4 months, we went back to almost exclusively in-person visits. But it left us with a residual telehealth platform that was focused on provider to in-home telehealth, and we continue to use that to this day. The in-home telehealth platform that we use now is all within Epic, our EHR. Again, we had that spike in use and it declined. Current use at Children's, behavioral health uses it a lot. It's perfect for behavioral health because you really just need to talk to the family or patient, and you certainly don't need to do a physical exam most of the time. And of course, the video connection is obviously essential for making that conversation more personal than a telephone call. But it really works beautifully in behavioral health. Subspecialty telehealth has continued, but it's limited. Less than 5% of our visits are via telehealth, unfortunately. Barriers, not all providers do it. Some providers have just said, I just don't want to deal with it. I don't want to do it, which is really unfortunate because it means a patient may come from one of your clinics and drive 3.5 hours to see such a provider. They'll see them in Atlanta, And they may be an ideal candidate for telehealth for follow-up, but they've established a relationship with a provider that doesn't offer telehealth. Not ideal. They could switch providers, but that's always awkward. Doesn't get offered to them, frankly. And so they're sort of stuck going back and forth. So that's unfortunate. I hope we can change that down the road. We don't require people to do telehealth. So I don't know the exact percentage, but it's less than 50%. And most of our providers are reluctant to do it for their first visit for a patient, which I think is really unfortunate as well. And I think what we're going to be doing is proving to providers that it works through the program that we're doing in collaboration with all of you. They feel like they're not going to establish a relationship, that the physical exam is critical, that it's just not a good way to start off things. It's also some people, more administrators view it as inefficient and not cost effective because it can't be put into our usual clinic model exactly the way they'd like. The reality is it does save our institution a tremendous amount of money. We have a 6th-floor, beautiful clinic building, but we're going to run out of rooms. If we could do a third of our visits via telehealth, that'd be like adding 2 more floors to our clinic building because none of those visits would occur in the clinic. They would all occur via telehealth, and we would tremendously increase our long-term capacity. And so I think if we could convince people of that, hopefully there'll be more enthusiasm. Why are some providers reluctant? Why are some people not doing it? Well, it seems impersonal, technology barriers, just like some of our patients are technology phobic. Some of the physicians are technology phobic. You know, they don't want to, they're not sure, they don't like having to deal with additional technology, and so they don't do it. The lack of a physical examination. Our pulmonologists really don't like to do telehealth because they want to listen to the patient's lungs, and they feel for most visits that's critical. There's also concern about delays in labs and imaging. You see the patient in their home, you have to wait for them to go to the lab, which they have to travel to and arrange. While if they're in clinic, they go downstairs, they get their blood drawn, and they go home, and you'll have the results the next day. Imaging as well. And the imaging, local imaging may be, for certain things, may not be everything that we'd like it to be, may not be easy to compare to previous imaging. Why do some providers do? Why do I do it? Well, I like the convenience for patients and families. My patients who do it love it. Families are asking for it. I think for a health system not to offer it, and for not every provider to offer it, is going to become a thing of the past at some point. It's also, frankly, it's an easy way to add a patient to my schedule. If a patient calls and they need to be seen urgently, I can either overbook them, which is never fun, or I can try and find clinic space, which is never fun, or I can just see them in my office via telehealth visit. Very easy to do. Children's telemedicine. Some of the nice things that we have is we have video translators available in any language. So if a patient does not speak English and needs to be seen via telemedicine, we can have a video translator join the visit. We can see the patient, we can see the translator, and everybody can see me, and we can do the visit that way. We can also have multiple people join, which is lovely. So, Dad is home with the kids. He's going to do the telemedicine visit. Mom is at work, but she wants to participate. She can join from work. Dad can join from home. I can join from my office, and we can have a 3-way conversation. Really, really nice. So what are we doing here in this partnership, Georgia Rural Health Innovation Center and Children's Partnership? You've heard about it. We're partnering on a lot of different things. But in terms of telemedicine, what are we doing? Well, I just want to acknowledge the leaders of this program, Kedrick, Ed, and Jennifer on the Rural Health Innovation Center side, and then Pam, Emma, and myself on the Children's Healthcare of Atlanta side. We've all been really working really hard together, and it's been a wonderful partnership to try and make this program work. What's the goal of our program? It's to have telehealth visits in the pediatrician's office. So equipment has been placed in 5 offices, as you'll see, and the patient will come into the office and they will get checked in. They'll have vitals, they'll have weight, height, and then the subspecialist will log in and we'll have a telehealth visit, and the visit will include a stethoscope, an otoscope, an ophthalmoscope, a magnifier for skin exam. I'll tell you, a telehealth otoscope is way better than one in my office because it's magnified, it's beautiful images. Really, same thing with the skin exam. You can see details that you wouldn't be able to see with your naked eye. And the stethoscope exam is also excellent. So it's really an enhanced visit. The difference for us is that instead of using the video through Epic, our EHR, we use the video called Pathways through the Georgia Partnership for Telehealth. And that's what enables us to use the fancy equipment. That's what enables us to use the equipment that's in the office. But it's really very similar to a usual visit. We usually have 2 windows, one for documenting in the EHR and one for video. Whether it's the Epic video or the Pathways video, it's really very interchangeable. You don't notice the difference. Very intuitive to do for the subspecialist. So this is the basic pattern. The pediatrician identifies a patient who requires subspecialty consultation and requests a consultation. Patient is scheduled for a telemedicine visit in the pediatrician's office with a subspecialist. The visit includes vital signs, medications, and use of telemedicine equipment in that office. The follow-up options can be in the office again. It could be a visit to Children's, driving up to Atlanta, or it could be home telemedicine. Whatever is going to work best for that particular patient and clinical situation. One thing we have built into it is pediatricians getting logged into Access CHOA, which is our portal for pediatricians to see everything that's in our EHR. The nice thing about that is if their patient who we've seen gets admitted, they'll get a notification that they've been admitted. If they end up coming to Atlanta for a visit, they will be able to see the results of all the testing that was done. And they will be able to download the after-visit summary that was produced by the telemedicine visit in their office and hand it to the patient. The other thing is MyChart enrollment. That's our patient portal that we use at Children's for patients. And what we want is we don't want these patients who are seen in the office to have lose access to us. The patient portal means that they can now email us with questions. They need a refill. Their child is having a problem. They can essentially email us through the patient portal. We can send information back to them. If they lost their AVS, they can see it in the patient portal. They have access to all of those ingredients. So we want them not to have a visit and then be sort of left on their own and just relying on good old-fashioned telephone calls. We want them to have the full experience of being a patient in our practice. And then again, this uses this Epic Pathways hybrid visit, which really works quite nicely and enables us to do a more complete physical exam. I met with our gastroenterologist who's going to be doing these, and she was just excited to be able to do telemedicine. She does telemedicine now, but to be able to do telemedicine and have a weight on the patient that's accurate, because that's so critical for a gastroenterologist for a number of different conditions. And now she'll be able to have that in these sorts of visits. And these are the offices. A few of the pioneers that are in the people who are in the first wave of pediatricians, can you stand up? A few of you are here. Oh, fantastic. So these are my heroes. They've volunteered to be guinea pigs and do this. And I've talked with all of them on the phone and to get an assessment of what they need, and so to try and meet their needs. But I've been just overwhelmed by their enthusiasm for providing care to their patients and their enthusiasm about this program. And so thank you all very much. And you can see we've got a nice distribution in rural Georgia, but we are bringing on a second wave. This is cohort 2. They're just being started online. Are any of those pediatricians here today? Could they stand, please? Excellent. Thank you. You're getting a preview of what's in store. And you can see by overlaying these two maps that we're starting to cover more and more of rural Georgia, even northeast Georgia. So this is very exciting. And the hope is that this expansion will continue. This is the first cohort of the practices, five practices, a few more providers. These are the participating subspecialties. We've got 11 subspecialties available. There are a few obvious gaps. I talked about dermatology. We don't have dermatology. And part of that is that pediatric dermatology at our institution is not part of children's. These are all children's subspecialists. Pediatric dermatology belongs to Emory, which operates on a different system and so forth. And so just getting started, I didn't want to try to get a whole different system plugged in. But my hope is once we get up and running that we'll get pediatric dermatology to participate. It doesn't include genetics, which is also a Emory-based system. But again, hopefully, as we show that this works, we'll get genetics involved as well. And there may be a few other areas that we'll be able to add down the road. So we've got a pretty broad selection. In some areas, we've got 2. We've got 1 neurologist that does headaches and 1 neurologist that does seizures. So you're even getting subspecialists. And then what are the advantages of in-office telemedicine? Decreases the digital divide. If we're relying on the patient in their home, sometimes the visit just doesn't work. I've done these. You go to make the visit, they can't get onto the internet, the technology fails, the visit never happens. By doing it in the pediatrician's office, they'll have internet access, they'll have equipment that's extraordinarily high quality, better than what I have at home, and they'll have expertise helping them before and after the visit. Are they having trouble logging in to MyChart? We will provide them with that support. They'll have a physical examination. Again, a huge gap when you do it in the home. And then the practice involvement, I think, is going to be so beneficial in the long run. They'll be recording medications, so doing some mundane things, but also provide education and support to the patient and caregiver. So as a nephrologist, I might see a patient with high blood pressure and I prescribe a medication, and right then and there, they can be set up with a follow-up in the pediatrician's office. So we'll know in a week whether I prescribe the right medicine at the right dose or whether we need to make a new game plan. As opposed to if I do it in home, that communication wouldn't be there so easily. Office visit in Atlanta. Are some of these patients going to need to come to Atlanta, even if they do their first visit in the office? Probably yes. But many of them won't. I've had patients who I've done initial visits in rural Georgia, and they never come to Atlanta. So often I see a lot of patients who are what I call the worried well. They have some abnormality on a renal ultrasound that's concerning, but I'm able to provide them with reassurance. It's a normal variant. They don't need any follow-up. Case closed, never travel to Atlanta. Or it could be a chronic problem that you can manage via telemedicine. I have a boy who has actually pretty severe chronic kidney disease, has a GFR of a little bit less than 50% of normal. We diagnosed him by mailing a kit for him to get a saliva sample at home and mail it to the genetic company, and we diagnosed him with a genetic kidney disease. He's never been to Atlanta. I've done about 8 visits with him. I work closely with his pediatrician. She gets blood pressures and so forth. Because she told me when she first called me about this patient, this family will never make it to Atlanta. It's just not going to happen. At some point in his life, unfortunately, he probably will when he needs a kidney transplant. I haven't figured out a way to do that via telemedicine yet. Anybody with ideas? Probably not. But he's never been to Atlanta. I followed him for about 3 years. But with collaboration with his pediatrician, he doesn't need to come to Atlanta. She facilitates his labs, gets his blood pressure, gives me his weight, gives me his height, does a physical exam. Everything works out nicely. The other way we can do this is optimize the visit in Atlanta. I'll get referred a patient who's driven 4 hours to see me, and I see them and I say, you need a nuclear medicine study that we need to do here in Atlanta. So why don't you drive back home 4 hours, and next week drive back here 4 hours, get your nuclear medicine study, and then drive back home, and I'll call you with the results. Not very efficient. So if I did that initial visit in the office, I would realize that they needed a nuclear medicine study, and we could arrange a clinic visit to follow up that initial telemedicine visit where they get their nuclear medicine study. They also see the urologist that they need to see, because I didn't know that before if they came to see me in person, and see me as well. So they get 3 things instead of 1 thing where they have to come back maybe a second time or third time to get a complete evaluation. And then pediatrician subspecialty collaboration. I'm on time, it seems. Before, during, and after the visit. I'm really excited about this. Ongoing one-on-one collaboration. I'm one of 13 pediatric nephrologists, but I'm the only one doing this telehealth in rural Georgia. So that means I'm going to develop relationships with all of you. And I'm really excited with that, both for the current patient, that one who needs the nuclear medicine scan or has chronic kidney disease, but for future patients as well. I used to do a clinic in Athens, Georgia. And unfortunately, the hospital that ran it closed it down a couple of years ago. But I gave all the pediatricians in the Athens area my cell phone number because I was the only pediatric nephrologist that took care of their patients because I went to Athens. And so they were able to contact me. So that relationship building, I think, will be very, very nice. Access CHOA will enable you to, as I said, have that 2-way communication, notifications regarding hospitalizations, clinic records. And then again, I love the idea of echo collaboration. If Dr. Tarbutton sees how I approach a kid with hypertension once, the next time she gets a kid with hypertension who she's thinking of referring to me, she'll do all the tests before she even sends them to me. Because she'll have seen that, knows what I like, knows what to do, and maybe doesn't even need to send the kid to me. Because we've had that collaboration and relationship, and she's seen the whole approach. She can ask me questions if necessary, but we can minimize the need for subspecialty care or make subspecialty care that does need to occur much, much more efficient. All right, last question and the end of the talk. What is the most important benefit of this program? Is it, increased access to subspecialists for rural children, decreased travel for medical care for rural families, improved partnership between rural pediatricians and pediatric subspecialists, or reduction of the digital divide for rural families? What do you think is the most important part of this program? All right. There's not a right answer. Just wanted to get your input. So it seems like access to subspecialists, but obviously many of you value a number of other parts of the program, and hopefully you find value to all of these potential parts of the program. All right, and that's it. Thank you very much for your attention, and I'd be happy to answer any questions.
Well, I have a question, Dr. Greenbaum. Thank you for your presentation. How robust is the recruiting for adding additional rural partners? And do we have the resources? And I'm thinking, partners in good housing in each counties, please.
Yeah, so we're rolling it out slowly for a number of reasons. One is we've never done this before, so we started with 5 practices, and we're just getting started, really. We have clinic openings in June, and those will be our first clinics, and so we wanted to get it going, and then we're doing another wave of pediatricians, but there are the resources and there's the will to add additional sites at some pace. I don't know what the max would be, but we definitely want to move it forward. And obviously, if we can prove the value of it, that will make it even easier to add additional sites. Sure. Other questions? Please.
Good morning, and thank you for the presentation. My quick question is, how are you able to use the application to be able to reach a platform from all bases of education levels? One great example is I work with the Department of Veterans Affairs, and most of our veterans from World War II to Vietnam, virtually, or however that more of those in Iraqi freedom, those in the modern technology, they're able to access it. So is there a way that you made it simple to where a third grader can do it so they can reach out? And also with the ever-changing diversity going on, is it done like in Spanish or any other thing so it can be reached all over to all platforms? So that's just my question.
Yeah, so I mean, we're fortunate in pediatrics is that between our patients and our caregivers, most of them are a little younger than the cohort that you're talking about. Although I just saw a kid with new onset kidney failure who's cared for by his great grandmother and great grandfather. So they were definitely in that generation. So the nice thing about this program is they're plugging in, they're going to the pediatrician's office. So there are people in that office that can facilitate them logging on and doing all of those things. Now, getting them to use MyChart effectively and so forth, that's a challenge. Communicating via email in our EHR, we find universally that the more socially disadvantaged patients are less either willing or able to use that way of communication. And we have programs that we've tried to implement. We've tried, and unfortunately, we haven't been able to very effectively increase that utilization. So it's an ongoing challenge. Sure. All right. Well, thank you very much.
Thank you.